Good evening, everybody. We'd like to welcome you all to this evening OrthoTV webinar. I'm glad to invite Dr. B Shivashankar. He has done his undergraduation from Hubli and post-graduation from Solapur with additional training in Mumbai, Birmingham, and Stuttgart, Germany. He is practicing in Solapur at Ayer Orthopedic Center since 1993. He is known all over the country for his innovative work in field of orthopedics, especially techniques fixed with name Solapur. For example, Solapur technique of interlocking nailing, Solapur type of external fixator for distal radius fractures, Solapur sleeve for keyhole surgeries of femur, Solapur sleeve for keyhole DHS and modified instrumentation for DHS, Solapur broken nail extractors, Solapur adapter of key nail extraction, Solapur condyle screw for femur and tibia, and so on. His name is synonymous with interlock nailing in India, and he has passion for teaching this by simplifying the technique. He has conducted more than 500 workshops and live demonstrations all over India on various interlocking techniques. He is also one of the trio that is instrumental in formation of NAILS, or National Association of Interlocking Surgeons in India. So we welcome you, sir, for this webinar, and thank you for accepting this invitation. And we are eager to listen to your presentation on Z effects and your views. Welcome, sir.
Thank you, Dr. Ashok Shah, and thank you for that nice introduction. And as Ashok has rightly said, I am working at Ayer Orthopedic Center, a small orthopedic setup. I am in totally private practice, and I'll be talking on my views about Z effect and how it can be minimized. This is an X-ray made by one of my friend, Dr. Patel. This is the X-ray at the end of 5 months. He asked me a simple question. Sir, is this condition could have been avoided? What went wrong? I do keep getting such X-rays on and off on my personal WhatsApp. And after seeing this X-ray, I wrote to him saying that it's not possible just to comment seeing one X-ray. If there are any immediate pre-operative X-ray and immediate post-operative X-ray, it will be helpful to analyze the cause. So these were the X-rays shared by him. See, and he has done a nice long PFN in that case. And it's a unstable fracture where I have written number 2 because you can see a posterior fragment as well as the medial fragment separate. And if you see at number 1, the screws are out on day 1 itself. So my answer to him was, screws are longer outside. Traction was probably not released on table, or fracture has not been compacted or compressed on table. That's why the screws are outside in the immediate post-operative X-ray. And the screw which are outside can rock in and rock out, or also toggle within the nail, leading to Z effect. That is what has happened in this case sent by Dr. Patel. What is Z effect? One of the screw moves inside and the other one comes out. That is called as Z effect. It's an inherent problem with a 2-screw system. Friends, intramedullary nails with 2 lag screw system were designed to improve rotational control and bony purchase within the femoral head, thus resisting the cutouts and the implant failure, which was very common then when we were using the gamma nail or a single screw system. This implant design, however, has led to the recognition of a new failure pattern, the Z effect. Here you can see the superior screw going inside and the inferior screw coming out. This is called the Z effect. The opposite of the same is the mirror image of the same, which is called as the reverse Z effect, where the superior screw walks out and the inferior screw gets penetrated deeper. As I said earlier, Both Z and reverse Z effect are inherent problem of two-screw system. Why it is called Z effect? If you see one of the screw going in and the other going out, looks like a Z in the English alphabet, and that's why it is called as a Z effect. K. Egol in the Journal of Orthopedic Research in 2007 has beautifully described this Z effect and reverse Z phenomena. It's based upon variable bone densities of femoral head neck housing the proximal two screws. That is one of the reasons he contemplates. The femoral head has a various densities at different parts. That's why the screw strength is different at different places of fixation. And finally, he says the exact form is unknown or it is idiopathic. And he concludes saying, try to avoid two screw system like PFN in a medial cortical combination. In a medial cortical combination, his advice is to avoid two screw system. Friends, screw coming out, all of them are not Z effect. Here is an elderly 82-year-old lady. She was having a unstable intertrochanteric fracture with pertrochanteric fracture, treated with a PFM. This is the X-ray at 6 weeks where the superior screw is walking out, and at this stage the patient was put on guarded weight bearing, and at 3 months you can see the fracture healed quite well and the superior screw totally walked out and it was removed. And this was the final X-ray of the removal of the superior screw. If you see the position of the inferior screw, it has never changed. It has remained same all throughout. So the superior screw probably had less purchase in an osteoporotic bone and that has walked out. So this is not a Z effect. So this is an osteoporotic backing out of one of the screw. It is, though it is called as a problem in two screw system, I say that it happens even with a single screw system. Here you can see the cervical screw in a PFN A2 walking inside, or the helical blade walking inside and penetrating into the acetabulum. And the down you can see a PFN A2 walking out. Unfortunately, in a PFN we have the two screws, whereas here we have only one screw. So either the screw walks in or walks out. The mechanism is almost always similar to the Z phenomena which happens with two screw system. So even in single screw system also, the screw can walk in or walk out of the nail. These are some of the explanation for why Z effect happens. I have been talking about this for quite some time and I have seen the literature. There are varieties of explanation which is given for this phenomena. There are more than 40 types of explanation available, but the best I thought is the one here by Millay in the Interscience in 2007. What he says is, in an intertrochanteric fracture, when the hip is loaded, gradually the fracture collapses and the gap at the intertrochanteric fracture becomes less and less. If there is a medial combination as marked here with the blue triangle, when the hip is loaded from the top, the neck collapses less on the superior part and more on the inferior part. This differential collapse because of the gap causes the inferior screw to walk out more outside. That leads to jamming of the superior screw within the nail, and this jamming gradually causes the superior screw to walk inside, or every walking movement or even the muscle contraction, the superior screw goes inside and the inferior screw comes out, leading to the Z effect. That is in this fashion. So in the paper, he advocated that the concept of two screw system nowadays in the proximal nail is completely changing, and the trend is to go for single screw or thicker screw or a helical blade to avoid this Z phenomena with a two screw system. This is an X-ray shared by Dr. Amit, my friend from Belgaum. I did a workshop and live surgical demonstration there. In the immediate next week, he did 2 cases on one day and he sent me these X-rays. On the left, you can see the beak of the proximal fragment going into the medullary canal. That indicates that this is a varus reduction. So, though people call it a diamond Houston type of osteotomy, this diamond Houston type of osteotomy with a nail cannot happen. It can only happen with a surface implant to get a valgus reduction. If you are using an intramedullary implant, it's always a varus reduction. This is another case which he has beautifully done, a high subtrochanteric fracture. But unfortunately, if you analyze, the superior screw is longer. So what I wrote to him, the first case is reduced in varus and locked statically. So superior cutout of the screw is very, very high. And the second case, the proximal screw is longer as well as static locking has been done. Hence, chances of Z effect or superior bolt is very, very high. This, why I am showing this? This we can predict on day 1 itself whether your fixation is good enough or whether your fixation is wrong or there is something wrong and how to improve. That's the reason why I am showing this example. What happened to these 2 cases, I don't know, but definitely this is the principle on which my talk is based. Coming to the process of Z effect, as I said, it's totally my personal views with over 15 to 20 years of experience in PFN and intramedullary nailing for intertrochanteric fractures. The first and foremost is the superior screw, which is longer. The second foremost complication is cervical screw shorter, that is increased TAD. The third one is varus reduction. Again, a very common phenomena in intertrochanteric fracture when somebody does nailing. Fourth is the medial void. Varus and medial void, both of them work almost similarly. Next is no dynamization is possible, or static locking has been done, or a nail which is thick has been used, which is stuck in the medullary canal or in the isthmus. Friends, this is a topic for debate because many of my friends do get good result with static locking, and I am the only one proposing dynamic locking since many years. And again, as I said, over 95% of the patients, whether you do static locking or dynamic locking, they get off well without any problem. But I feel that about 5% of people require dynamization, which is available only in a nail, in the dynamic hole of the nail. That makes the difference. And if you can do dynamization in time, that problem can be solved. But unfortunately, our patients may not come in time. To avoid that, I try to do dynamic locking from day 1. The next cause is screw longer outside and fracture not compacted or compressed on table. And the last one is osteoporosis or idiopathic, where the explanation, you cannot give an explanation after seeing the X-rays. So these are some of the causes in my views, and many of them are multifactorial, means a varus reduction will be there, the screw will be longer outside, fracture may not be compacted on table, etc. It's many a time, it's multifactorial. Let me take each one after the other. The first one, superior screw longer. Here you can see the superior screw has been longer in this case. When the hip is loaded, it's loaded from eccentrically from the top. If the superior screw is longer, normally we advocate both of them should be at the same horizontal level so that both of them can take the load simultaneously and slide simultaneously. But if the superior screw is longer, that takes the load first, and that will cause varus deformity at the fracture site, leading to jamming of the superior screw and causing in turn superior screw to migrate inside or breakage of the superior screw. That's the most common factor what I come across in these cases for Z effect. Again here, another case, a superior screw is longer, but here in this case, a reverse Z effect has happened, again almost on the similar mechanical basis. The next is shorter cervical screw. or longer EAD. Friends, we all know this Baumgartner's principle of screw position and the tip apex distance for DHS. It's not only for DHS, this is applicable even for intermedullary nails like PFN, EPFN or any other even single screw system. Normally, we measure the distance from the fovea centralis for tip apex distance, but I advocate you to measure it from the subchondral bone, because many a time our cervical screw or the main screw will be in the part of the head and neck, and hence you have to measure not from it should be measured from the subchondral bone. It should be less than 25 millimeter to get good result. Here you can see the same case which I had shown earlier. The tip apex distance of the main cervical screw or the inferior screw is long. Because of the longer tip apex distance, the fracture has gone into the Z effect. So PAD is also a good predictor of Z effect. Here you can see a longer superior screw as well as shorter inferior screw. On the X-ray on the right, you can clearly see the superior screw breaking at the screw shaft interface, as well as the inferior screw walking out, leading to varus at the fracture site. So shorter cervical screw is the next cause. Varus reduction or medial void are almost similar in function. That's why I'm taking them, both of them simultaneously. That's the main cause next. Here you can see the fracture has been fixed beautifully with a PFN, but if you look at the position of the neck screw, it is kissing the calcar inferiorly at the neck, whereas it's in the central or superior part of the head. The tip of the screw is in the central or superior part of the head. So it indicates that the fracture has gone into varus. The reason is the nail has been inserted from the fracture side without making space for the nail. So you can see the widening of the entry side, and because of this varus, instead of the head and neck sliding along the screw towards the nail and compacting the fracture, the varus forces are the direct forces which causes varus are more, and that leads to superior cutout of the screw or backing out of the screw. As you can see in the next two cases, where the peak of the neck is inside the medullary canal. As I said earlier, this is not Diamond-Houston stable or valgus reduction, it's a varus reduction. Please remember, if the beak is inside the medullary canal of the distal fragment, that means it's a varus reduction. Recently, a beautiful terminology has been coined for this. It is called as a negative cortical contact. I will come to that little later. Another case, the same case on the left, which has gone into Z effect in due course of time after the beak has collapsed and touching the nail. Varus increase the risk of the device cutout also, because instead of sliding along the neck in this fashion, the load is more because the varus of the head and neck, and gradually both the bones start cutting out superiorly, as demonstrated in this case. Another case, again you can see that the beak is within the medullary canal and varus reduction, and as expected the fracture has gone into Z effect. Friends, I have been seeing this. Many of them are my own cases which happened in my own hands between 2000 and 2010. But since 2010, none of this has happened in my hands because of better understanding of the EFN. The last case, only case which has happened after 2010 is a stuck up nail. It happened to me in 2013. I'll show that subsequently. Another case, again operated sometime in 2008, a varus reduction. You can see that the neck screw, though it is touching the calcar, it's in the central part of the head. There is no valgus obtained, though the medial cortical support is good. The Shenton nail line has been maintained beautifully well, but the head and neck has gone into varus, and widening of the entry site has happened because of improper reaming at the entry site. And when the screw shaft is touching the calcar and the screw is in the central part of the head or in the superior part of the head, that indicates that it's a varus reduction. Again, that's a cause for failure. As expected, this also went into Z effect. Fortunately, the head of the superior screw could not go through the nail and hence it stopped short of entering into the joint. And once the fracture healed, I removed this implant since the hip was not damaged and this could be salvaged in this fashion. Another case where a high subtrochanter fracture, somebody has inserted the nail at the fracture site without even going through the trochanter. So again, this tilting and shifting of the head has led to the varus and Z effect in turn. Next commonest cause is the medial void. In an unstable trochanteric fracture, where the lesser trochanter is broken, there is a gap medially, and that gap requires to be collapsed. As said earlier, the inferior part of the head and neck tries to collapse more than the superior part, and that leads to jamming of the superior screw, and hence the Z effect happens in these cases. And you can see, fortunately, the fracture united by this time, so the Z effect has started in this case. Again, just a repetition of the same. If there is gap inferiorly or void medially, when the head is loaded from the top and the inferior part tries to collapse more because the superior part is already touching, only the inferior screw tries to back out and jamming of the superior screw happens within the nail at the nail screw interface, and that causes the superior screw to migrate inside. So if you have got a medial void case, then definitely this is a problem, should be taken care. How to avoid it, we will discuss subsequently. Next one is no dynamization possible or static locking or stuck nail. Again, as I said earlier, it's a controversial topic. Here you can see a static locking nailing has been done, again which has led to Z effect. Another case, a static locking has been done, beautiful reduction. Head and neck, I cannot find any fault with the reduction in the AP or in the lateral picture, but in due course of time, the screw migrated, and the surgeon tried to salvage this by removing the static bolt, but unfortunately you can see the dynamic bolt is also at the superior part of the hole. It's already in the static position, so this could not be caused, and this was the end result in this case. Stuck up nail, again no dynamization is possible, though in this case this is the last case I had Z effect in my own hands. This is operated sometime in late 2012. This is the X-ray in 2013 December, almost about 1 year after subsequently. You can see that the nail is thick and I have hammered the nail inside. Though I have done the distal dynamic locking, but the nail is snugly fitting. Here you can see at the tip of the nail a crack also in this case. So this patient, though the initial X-rays were beautiful, which I couldn't find out for this presentation, but subsequently at 1 year you can see the inferior screw is coming out, the superior bolt is broken at the junction of the nail, with the shaft itself it is broken, and the head has subsequently gone into varus. So this is the end result in that patient. So stuck up nail or nail which cannot be dynamized is another cause. So it's if you are done a static locking, it's better to do dynamization if required in time. The next cause is screw longer outside or fracture not compacted. That will in turn lead to screw longer outside. So I am taking both of them together. Here you can see the screw is longer outside. Another case, both the screws are longer outside. Another immediate post-op X-ray, the screws are longer outside. So what happens when the screw is longer outside? This can toggle, and that will cause losing of the purchase, and sometimes one of the screws also get less differential toggling happens and one of them gets stuck up. Another reason is not releasing the traction. The first reason is using a little longer screw. It's the laziness of us. Instead of changing the screw on table, we just accept sometimes a little longer screw without changing it. So that has happened even in me, that is long time back, not in the last 10 years. But here, another second reason is not releasing the traction on table. Many a time to get a beautiful reduction on table, orthopedic table, we give traction to the limb. But when we insert the screw, we forget to release the screw. Always try to release the traction slightly once the guide wire is inside. Once you insert the nail and the screws partly, you release the traction totally and compact it. So the fracture should be compacted on table to avoid the screw backing out in the immediate post-operative X-ray. What happens if you don't release the traction? The fracture gap becomes less in the immediate post-operative X-ray, and both the screws comes out, and it will be seen as a prominent screw outside. The patient will not be able to sleep on that side. The osteoporotic patient, even if they sleep on that side, that causes the rocking of the screw in and out. Every time the patient tries to move, or even the muscles are contracting or the tensor fascia is contracting, that causes the loss of fixation. Many a time, both the screw walks out, that's the commonest thing. But sometimes, toggling of the nail, screw in the nail, causes differential sliding due to one of the screw getting jammed and leading to the Z effect, as which is depicted in this picture. Here, a high subchondrial fracture with a very long oblique fracture. Statically, the nail has been locked statically, but because of the long obliqueness of the fracture, the distal fragment can slide into the expanded metaphyseal fragment into the proximal bone, and in due course of time, both of them walked out. Probably this could have been minimized by doing a dynamic locking. That's the reason why I say that it's better to do dynamic locking in some of the cases. Next is osteoporosis. Osteoporosis is from India, everywhere in the world, with the life expectancy increasing, the osteoporotic fractures as well as the problem of fixation in osteoporotic bone is very, very high. Here is an example of a 75-year-old lady where PFN A2 has been done, that has gone into varus, though the X-ray, the immediate post-operative X-ray is beautifully reduced, but you can see it gradually has gone into varus and the screw walking out. Another case, one side already the patient had a PFN, she fell and had a PFN A2 inserted on the right side, and you can see that also walking out. Another X-ray of a severely osteoporotic patient where a PFN A2 was done with a good valgus reduction, but unfortunately because of the osteoporosis, the screw lost their purchase. Idiopathic. Sometimes you cannot explain why this happened. This is a 3-year-old post-operative X-ray shared by Dr. Kanai on a WhatsApp group for discussion. At 4 years, you can see that the screw is backing out. This is probably because of differential flexibility of the bone and the implant. So the ideal implant is one which has got the similar flexibility like a bone, but I don't think any implant is ideal in the market. They are too stiff for a flexible bone. Hence, over the years, some of the implant takes the load and leads to breakage of the implant also. Even after the fracture effects, I have seen some of the implant breaking, and this is an example of a implant walking to a Z effect. See, this is, as I said earlier, this is a single screw. That's why I call it as a walking out rather than calling it a Z effect. Another case which I have shown earlier, courtesy my friend Dr. Sambaram from Sholapur, which we discussed on India long time back, where a static locking has been done with a beautiful reduction, but in due course of time, it has gone into a Z effect. When you have got a good reduction, it's difficult to explain, and that's why I call these things as a Z effect. Finally, many a time it's multifactorial. Here in this case, you can see a longer screw outside from day one and also static locking, and that led to Z effect and breakage of the superior screw. Friends, as I said initially, Z effect is multifactorial. The commonest causes poor reduction, osteoporosis, longer screw, and not compressing the fracture on table. These are the commonest factors I find in these X-rays. Once you know the causes of Z effect, how we can minimize? This is the topic. I know I cannot say it can be avoided, as it is idiopathic. Many a time we don't know the exact cause. That's why I'm talking about how to minimize the Z effect. The first question is whether single screw is better than one. To avoid Z effect, we have enough number of papers which propagate single screw system or the helical blade system, especially in osteoporotic fracture, helical blade system which can compact the bone, which are marketed in the by the many companies. So my first question I'm going to answer is whether single screw is better than double screw. This is a paper from Greece. Treatment of extracapsular hip fractures with the proximal femoral line, long-term results of 45 patients. They had only 2 cutouts when compared to a single screw system, and they conclude saying that in addition of 6.5 millimeter anti-rotation hip pin to reduce the incidence of implant cutout and the rotation of cervicocephalic fragment is the main thing, the advantage of putting a second screw. So they conclude saying that addition of anti-rotation hip pin reduces the cutout rate. So there is no question of shifting out to one screw system. It's definitely better to use a 2 screw system. My friend Professor Amit Rastogi from Banaras Hindu University, Varanasi, head of the department of BHU Upgrade Department, he has done a beautiful study in association with IIT BHU Varanasi. He compares intermediate single screw system with a double screw system. This is a very old article where he has compared the gamma nail with the TFM. You can see how he has done an unstable situation in a bone model is by removing a centimeter of the bone in the medial part of the just above the lesser trochanter and fixing this with TFM or gamma nail. He used them on a machine and tested. This is the gap he has created, and this bone model were tied over a testing machine for repeated loading. And friends, the final result was only 1 out of the 9 PFN group failed, where he had used 2 screw system. See, the gap is so much. So even in all these cases, only one of them in 9 failed, whereas 5 out of 9 gamma nail group failed. And also he concludes saying that PFN sustained more number of loads. 8 of them sustained 50,000 cycles, whereas none of them completed 50,000 cycles in the gamma nail group. So that's why we conclude saying that 2 screw system is always better than 1. So there is no question of going back to a single screw system. So 2 screw system is definitely better. This article by Julia, Sebastian and Peter in the Journal of Orthopedic Surgery and Research about the load distribution between the cephalic screws and in a dual lax screw trochanteric nail, that is PFM. They beautifully analyze on a computerized model the load distribution happening in the screws. The left down picture, where the inferior screw is subchondral and the superior screw is shorter than the inferior screw. That means both of them taking the load simultaneously at the same horizontal level. That's the first model they tested, and they found out that the inferior screw and the superior screw slid smoothly. The second model they used was longer superior screw. When longer superior screw was used, the load was taken by the superior screw. Then shorter inferior screw and longer superior screw and a normal superior screw and a shorter inferior screw. These are the different varieties they tested, and the outcome of the study, for your understanding, I am just saying the first one as a longer inferior screw is 105 millimeter screw and a shorter at the same horizontal level as in the next screw is the shorter one is the 90 millimeter screw, which is depicted in this picture. that gave the best outcome. And when the inferior screw was shorter and the superior screw was longer, that is inferior screw 90 millimeter, the superior screw, this is an arbitrary figure I have written not from the article, just for understanding purpose. When the superior screw is longer and the inferior screw is shorter, the load is taken totally by the superior screw, Z effect will happen. And when the superior screw is longer and the inferior screw is normal, then screw breakage is very, very high, because the tip of the screw takes the load. Instead of Z effect happening, the breakage of the screw is very, very high. So they conclude in their article saying that if inferior screw is longer, smooth sliding of the screw happens and uniform stress at the nail screw junction will be there. And they also conclude that there is least varus malformation when the inferior screw is the longest. Means if the inferior screw has got a subchondral purchase, then varus malformation is very, very difficult to happen. Even if there is a medial gap, we can use it. So based on this, I am giving few ideas how to minimize Z effect. So this is the model on which you can see that the inferior screw is longer and subchondral and the superior screw is shorter, and both of them will smoothly slide with least varus malformation. When the lateral sliding was largest if the inferior screw had the shortest length. So if the inferior screw is short, then the inferior screw slides out very smoothly. Only the superior screw gets jammed, causing the inferior screw to walk out and the superior screw to move inside, leading to Z effect. So these are some of the findings from that article. Again, explaining the same. Inferior screw is longer and the superior of them take the load simultaneously and both of them uniformly collapse at the fracture site and both of them come out uniformly. If the inferior screw is shorter and the superior screw is longer, what happens? The superior screw takes the brunt of the load and that will cause varus malformation forces. Instead of screw sliding out within the nail, the varus forces will be acting. The vector of the force will be more of varus deforming forces. That will cause the inferior screw to slide easily, but that will lead to maximum jamming and stress at the nail screw junction for the superior screw. So the inferior screw slides out and the superior screw slides inside, leading to Z effect. This is more so common if there is a void medially. So that is one of the reasons why if there is a void medially, we should try to avoid this system as said by the earlier speakers, but earlier articles. But anyway, I will try to give some solutions if there is a void also medially. Hence, how to minimize? As I said earlier, in my own hands in the last 8 or 9 years, there is only one Z effect. Prior to that, I had about a dozen or so in the initial 5-6 years of my practice. And some of the things I have noticed is reduction. One should avoid varus reduction and try to get a valgus reduction in all these cases. As you know, varus is bad for any fracture to heal, whether you are using a surface implant as well as an intramedullary implant. Valgus is good. Second one is screw length. Try to avoid longer superior screw. Avoid shorter inferior screw or a longer TAD. Avoid screw which is longer outside also. The screw head requires a support. The bone of the lateral cortex should be supporting the screw head. And also try to compress the fracture on table, releasing all the traction. And few cases, less than 5% maybe, requires a dynamization. It's better to do dynamic locking from day one rather than depending later on. First and foremost, reduction. Friends, in the last 10 years, I've been talking about the anteromedial reduction. And even in the last webinar, my friend Dr. Gadigone stressed on the anteromedial reduction and he gave due credit to my teachings all over India. I always show this picture. The anterior cortex is thick cortical bone which has got less comminution, like the jigsaw puzzle of a face with only few pieces. Whereas the posterior cortex is comminuted, osteoporotic, it's hundreds of pieces. It's difficult to put the posterior cortex back rather than putting the anterior cortex well. That's why try to reduce the anterior cortex. If you reduce the anterior cortex properly, the posterior cortex automatically gets aligned properly. It may not be reduced properly, but it will get aligned properly. That's very, very important. I also give another example. It's like putting the first button of the shirt properly. If you put the first button properly, the last button will also be at the same level. You can compare the first button of your shirt to the anterior cortex. If you reduce it properly, the last button, the posterior cortex, will be also aligned properly. If there is a difference, the first button is not put properly, then the problem arises. The posterior part also will not be reduced properly. So always what you can see, the thick anterior cortex, you reduce the anteromedial cortex. That is what I call it as Shiva's hypothesis. We all know the posteromedial comminution, which we have been talking over the years. Even as a resident, I learned about the posteromedial comminution. But what we are talking today is anteromedial reduction. What we can see, we can reduce. Just to depict the anteromedial reduction, the neck, when it is reduced, both of them at the fracture site should overlap 100% like this. If there is a loss of even 25% reduction, there will be another 25% reduction loss posteriorly. So I am demonstrating in this fashion. So you can see anteriorly as well as posteriorly there is loss of reduction. Only the central red portion is having the contact, where all the screws will come. Where is the bone to heal? That's why we face problem if the reduction is not proper. So anteromedial reduction is very, very important. These are some simple reduction tools. The most commonest I use is a Steelman pin on a T-handle check like this. Here you can see a neck on the left not properly reduced. The guide wire was not going properly. With a Steelman pin, I just pushed the neck down, aligned it in a better fashion. Another case. This is from Ocean, where you can see the neck is flexed in the lateral view. The beak is going anteriorly. With this beak, with the spatula has been reduced properly and the guide wire has been passed and the screw has been passed subsequently. So getting this reduction, anterior reduction is very, very important. So that's why we always say that anteromedial reduction is very, very important. How I do this anteromedial reduction? Because many people ask me every time how we do, how these cases. Friends, this is example. Both in AP and lateral picture, the neck is widely separated. This is untable. It's under traction, abduction, and external rotation. You can see a fairly good reduction. But if you see the lateral view, the neck is not 100% reduced. What I normally do is I pass a K-wire. Right, lower down picture, you can see the K-wire has been passed into the shaft, and then I insert a Steelman pin percutaneously from the anterolateral aspect, and I dip into the fracture site, and then I try to elevate. So once I elevate, both of them get aligned at the same horizontal level or the same line, with the neck is aligned properly. Immediately my assistant will drill the K-wire which was passed partly into the shaft, into the neck. Once the K-wire is passed into the neck properly, if it is coming in the way of the screw or the nail, I'll pass additional screws anterior to that. Otherwise, many a time this fixation is better. And normally 2 screws are fixed at 1 centimeter apart. At the left, you can see the AP picture are fixed. And once I have fixed the fracture, I can adduct it. I am least worried about varus happening. Without fixing this fracture, if I adduct the limb to insert the nail, varus at the fracture happens, superiorly opening of the fracture happens. That's why we should fix the wires which are very anteriorly placed. On the left, you can see in the abducted position, I cannot do nailing. Whereas in the right, in the adducted position, I have lot of space to the nail. So this is the adduction, almost 60 degrees of adduction I get in these patients, and it's easy for us to operate. And there is no question of varus happening because I have already fixed these fractures with KYS. This is an example. This was not a very ideal case. The reduction was fairly good, but just to demonstrate the technique of how I use the Steinman pin, this I did in the operative nailing course last year. Thanks to Dr. Rajendra Vankade from Kalyan, who has shot this video and shared this video with me. This is what we showed. This is from the screen. He has shot this video and sent this video.
We can't hear Dr. Rajen's audio. So can you explain us what is happening?
Yeah. You didn't get audio?
No, audio is not working.
Okay, then I'll go back the slide and I'll try to explain it, and I'll mute my video here.
Okay.
Friends, here I'm inserting percutaneous Steinman pin quite away from the artery. So it's for the anterolateral aspect. I'm inserting the Steinman pin. My right index is on the artery. So it's not from the end, it's from the anterolateral. I percutate this right Steinman pin and try to jump, insert this Steinman pin over the neck and try to feel the fracture and dip into the fracture. See, I'm sliding over the neck. I can feel the tip of this in the neck, and then I will insert this Steinman into the fracture. Once the Steinman pin is inserted into the fracture site, I just elevate the depressed fragment. So sometimes the neck is depressed, sometimes the shaft is depressed, whatever is depressed. So you have to push the Steinman pin toward the patient or pull the Steinman pin, as in this case, towards you. That will cause lifting of the neck properly. Once it is aligned, you can see that immediately my assistant, rather I have put the Steinman pin here and I am taking the K-wire and fixing the fracture. And once I fix K-wire, immediately I pass another K-wire, which is about a centimeter away. So this will be the fracture. And care should be taken that both these K-wires are very in place, so that we have either the screw or the nail. That's the only thing. This K-wire also give an idea about the direction, anti-version of the head and neck. So you can keep the jig parallel to this subsequently. This also reduces the radiation, especially when you take the lateral picture. Many a time, if your guide wire is parallel to these K-wires, or the jig is parallel to these K-wires, then many a time the position of the guide wire in the lateral picture will be very, very not acceptable. This is another case. And I go a step further. Even an undisplaced fracture also, cracked potential fracture also, I fix this with K-wires. The reason is when I insert the nail or the reamer from the top, that will cause separation superiorly and lead to varus. To prevent that, even an undisplaced crack fracture also, I fix these fractures properly with 2K wires which are placed anteriorly, and then I'll go ahead and do the nailing, whatever I'm comfortable with. Here in this case, I have used a PFN A2. This classification of medial support, which I have been talking since so many years, has recently been published, and they are classified into 3 groups based on the post-operative reduction of the medial cortical support. It's either negative, neutral, or positive. I'll give an example of all of them. Here you can see a negative medial cortical support. That is means the head and neck is in varus. This is a neutral cortical support. The Shenton's line is very well maintained. So this is what one tries to achieve, aims to achieve. But sometimes even in this, sometimes slipping of the medial cortical support happens. That's why what I normally advocate is get little, the bead should valgus. There should nearly about 5 mm. The head neck fragment should valgus. That is the positive support. So if the positive medial cortical support is there, then that also compensates for the shortening which happens due to collapse at the fracture site, and also that will help proper sliding of the screws in through the nail. If it's a or varus, time may not be that proper. That's why I always advocate valgus reduction in these cases, which has been published recently. Fracture reduction with positive medial cortical support, a key element in stability of reconstruction of unstable trochanteric hip fractures, published in Archive of Orthopedic Trauma and Surgery in 2015 by Chang, Zhang, Lee, and Dargel. Here you can see a negative medial cortical support with the beak is going inside or varus, and you can also see that the neck screws, though they are inferiorly placed, they are already in the middle or superior part of the head and neck. That also indicates that there is a varus reduction. So don't call this as a stable diamond Eustachian type of osteotomy. This I am repeatedly telling. There's a badly comminuted fracture in an alcoholic patient came to me long time back, sometime in 2008 or 9, I don't remember. But you can see the Shenton lane has been beautifully maintained, and the bone healed around the nail beautifully, even in spite of so much of comminution. So getting the cortical support right, both in AP and lateral, that is the anteromedial reduction, is very, very important in these cases. And this is the end result at the end of 4 months. This is the picture in 2011. Another X-ray, sometime operated in 2007. You can see a 15 days old fracture in an elderly lady of 55 years, 75 years. You can see a positive medial cortical support, and at 14 months, you can see I have tightened, compressed the fracture so well on table that there is no subsequent collapse happening. The screw heads are touching the lateral cortex, and the fracture has united without any problem. This is when these are the clinical in the immediate post-operative period. He has got a distal radial fracture also. The Solapur type of fixator, which Dr. Ashok Sham was talking about initially during my introduction, is this. Only 4 shank screws and a quadrilateral frame with a minimal implants, 5 clamps, 4 shank pins, and 2 connecting rods. We can do a quadrilateral frame fixator. So that's the Solapur frame. In the immediate pre-operative picture and the post-operative picture showing the good positive medial cortical support leading to good union. This is a case which I operated recently in February at Sajjati Hospital during the Pune trauma course. You can see the fracture is very badly comminuted. The lesser trochanter is broken, the lateral wall is broken, it's a high subtrochanteric fracture. So many problems in this patient, and I was doing a PFN in this patient. What I have done, since I wanted to get the valgus reduction, I inserted a Steinman pin into the proximal fragment and asked the assistant to adduct it totally. and I got a opening medially, getting a positive medial cortical support, though there is a gap. But friends, this is in valgus. So this gap, especially if there is a medial void, if you get a valgus reduction in this fashion, then compensate for the medial void, and this screw slides uniformly out. And this is the immediate post-operative X-ray in January, and just at 4 weeks time, Dr. Atul Patil, the head of the department, shared this picture at the end of 1 month. You can see beautifully the fracture is consolidated already. So this is the thing which you learn. If there is a void medially, you should try to get a valgus reduction. If I had obtained a valgus reduction in this case, this would have gone into failure. So getting valgus reduction is very important, and getting the neck screw or the cervical screw subchondral is also equally important in these type of cases. That brings to the variable is the screw position and length. Again, this picture, since you can see the X-ray itself, I did picture 2009. I have been using this repeatedly since 2009. This same picture in all my presentation. Both the screws should be at the same horizontal level so that both of them take the load simultaneously and slide. And the screw tip should be sub-3. As per the Baumgartner principle, the tip apex distance is measured from the fovea centralis. If I measure the distance from the fovea centralis, if my screw is in the interior part of the head and neck, definitely my TAD will be more, or the tip apex distance will be more. So friends, in an intramedullary implant, I request you to measure the TAD, not from the fovea centralis, but measure it from the subchondral bone, from the articular surface. So the TAD should be less than 25 millimeter, both in AP and lateral, or you can go still much more subchondrally to get the best fixation in this. I have been showing all on the left side. The superior screw longer, inferior screw shorter is wrong. Superior screw is longer, inferior screw shorter. Again, that is also not correct. And down the inferior, both the screws at the same tip, at the same level. Again, it is wrong. So what is correct is on the right side. Both of them should get the same horizontal level so that both of them can take the load simultaneously and slide back outside. So that's the thing. Second thing is not releasing practical cable. That will cause the screw to be outside. As I said earlier, that was talking of the screw. So you have to compact. See, this is the immediate post-operative X-ray. All the screw tips are touching, the screw heads are touching the lateral cortex. I have released the traction and I have compacted the fracture on table beautifully so that in the immediate post-operative X-ray, the screws are not backed out. That's very, very important. Sometimes due to collapse at the fracture site, it comes out slightly by about 2 or 5 millimeter outside. That's fine, but that is not in our hands. But this is tightening on table is in our hands. So we have to judiciously compress. On the right lower corner, that is 31/12/2005, that is the immediate post-operative X-ray. You can see the screws are touching the lateral cortex, and on the left, you can see 21/3/2016. Screws are again remaining at the same position. That indicates that I have compacted the fracture on table beautifully. The screws are not walking out. That is very, very important in these cases. How I compact this fracture? After, as I said earlier, after I pass the guide wire and the nail, a nail and the guide wire, I release the fracture slightly. Then I pass the superior screw first. And then I pass the inferior screws halfway through. Once I pass the superior screw halfway through, I release the traction. I compact the superior screw first. See that the length of the superior screw is proper. Then I will use the inferior screw accordingly. Normally, if I use a superior screw of 70 millimeter in a 135-degree nail, 15 millimeter longer, that is 85 millimeter inferior screw I select. And if I am using a 130-degree nail in an elderly patient, it's a 10 millimeter difference. And after passing both these screws, I compact both of them. Again, the audio may not work. That's why I'll be talking. The superior screw compressing, the inferior screw and compressing. I have released the again I am compressing the screw. Again I am compressing the screw. These have been judiciously put to the last years are probably since 2008 or 2009, and my complications rates have reduced drastically because of this. So, alternatively, compressing the fracture gets the head of the screw touching the lateral cortex, and rocking of the screw within the nail is prevented to a great extent, and that also prevents the screw to back out or Z effect to happen. So, this is the reason why I say that you should compress the fracture beautifully in all these cases. Sometimes the lateral wall may not be present or it might be comminuted. So how to compact these fractures is the next question. Friends, some of the nails like the Gamma nail or the Halifax nail or ZNN have got a compression screw or the set screw. You can compact the fracture with a compression device and lock the set screw so that the screw will remain at the same side and the compaction whatever you have obtained on table will not be lost. But you cannot get the sliding mechanism to happen. The next screw will not further slide within the nail. So there is a set screw which is sitting on the screw slot and preventing the sliding. Again, recent case I have done in this year only. Here you can see the lateral wall was compromised in this patient. What I did, I just screwed in the screw touching against the nail. The head of the nail is touching the nail itself. Head of the screw is touching the nail itself. So the lateral part of the nail is acting as a lateral cortex. If I had left the screw out little more outside, there would have been chances for toggling. So if the lateral cortex is missing, then you can get away without doing any additional thing by just tightening the screw against the nail. But only thing, the screw should be having a good head so that you can compress against the nail. That's the only requirement, because some of these screws are smooth and they might go inside. That's why I'm telling this. So not all these screws available in the market are uniform. They may not be having heads. So tighten the screw. The only problem here I find is because of the growth of bone over the lateral cortex or the over the screw head, removal if required will be difficult. That's the only problem. Then you have to dig this up or use a C-arm to get into the head of the screw and take this out. Otherwise, this gives beautiful lateral support. If there is a deficiency of lateral wall, you can use the technique without any problem. As I said earlier, you can see the beautiful consolidation just within a month's time in this case. Another case, a badly comminuted trochanteric fracture with a subtrochanteric extension. Again, you can see both the screw sets are touching the nail, and because you can see the valgus is too much. The reason is that the person was young and there was a severe valgus on the opposite side also. I am aiming at 5 degree extra valgus than the normal side. Always, that's my aim. So I have got that 5 degree extra valgus, and in due course of time, you can see beautifully the fracture has healed, and even I have removed the screw from this patient. So that's not a problem, digging out the screw. And these are the wounds in the same patient. Finally, you can see two incisions of the entry side and the neck screw insertion. I have not opened this fracture. My friend Dr. Shivashankar from Solapur has designed a trochanteric buttress plate. Similarly, my friend Dr. Naveen Thakkar from Ahmedabad also has devised a trochanteric buttress plate, and both of them does the same work. Lateral wall is deficient or not proper, then lateral wall is created by this metal or the plate, and against that you can compress the bone. This is my first case. Recently I have done this case. You can see the date as 21st of June. I have done this patient, a 92-year elderly lady with a basic cervical fracture and a high subtrochanteric fracture. So because of severe osteoporosis, I use this Dr. Shivashankar Benjale's trochanteric buttress plate, and I have compressed the fracture side beautifully against this plate. If I had not used this plate, I would have compressed definitely against the nail. But because of severe osteoporosis, I thought it's prudent to use this plate in this case. So this is an option you have got. If the lateral wall is missing, either you can use a plate or a washer and compress against that, or you can even compress against the nail as is shown earlier. So now the detection technique, and also the screw position, and also how to compress the fractures, we know how we can minimize the Z effect. The last part of my talk is what to do if Z effect happens in the patient instead of all this. Here, this is my own case, sometime operated in 2008, a basic cervical fracture with a subtrochanteric fracture. The proper instrumentation and the implants were not available where I operated, so I had to accept the longer screw in the immediate post-operative X-ray. And in due course of time, just after 4 days, is the picture which walked out. The initial 5 or 6 cases, all these 5 or 6 cases, I took back again in the OT, tried to reinsert the screw, different screws in different direction, but all of them came out on the second or third day again. So I came to conclusion that there is something inherent problem which is working. So already probably the first screw has caused a lot of damage to the fixation also. If Z effect happens, I just keep the patient in traction for some time, and then once the fracture becomes gummy, I just remove the complete screw. That's what I am doing in the last 7-8 years, and even I'm advocating the same. This is a case again operated sometime in 2008. You can see the superior screw had migrated inside, but luckily it had not penetrated into the joint. So I waited for the fracture to heal and removed this subsequently. This another case shared by my friend Dr. Asinki Gupta from Solapur, where a severe osteoporotic fracture, he converted that with a bipolar hemiarthroplasty. This is another case which we have already discussed, idiopathic the Z effect, where my friend Dr. Sambaram changed from 130 to 159. He also changed the nail and changed the direction of the screws. And luckily, this is the 6 months post-operative X-ray. The screws remained and the fracture united. There are only 2 X-rays I have got. So many people have shared me the success and the failures, but only 2 people have shared the success. Another one is from my friend Dr. Swapnil Kotadia, where there was osteomalacia in the patient where it is marked, and she had a intertrochanteric fracture, and the nailing was done, and the patient had Z effect at 3 weeks time, and he used bone substitute like Promas granules and reinserted the screws, and this is at 1 month. The screws are holding well, probably because of the Promas granules, and at 4 months again, probably the osteoporosis was the culprit in this case. And these are the only 2 X-rays I have got where reinsertion of the screw or changing of the nail and reinsertion of the screw, the success has been obtained. If you have anybody has got a successful story like this, please do share with me. Let me analyze the first. Friends, to conclude, there are some surgeon control factors to minimize the Z effect. Reduction has to be good anterior contact as well as good medial contact. Avoid varus and try to get valgus 5 degrees more than the normal side. It is called positive medial contact. Then screw length. Superior shorter screw than the inferior, means both of them should be same horizontal level. Avoid longer superior screw. Avoid shorter inferior screw or longer TAD. Then avoid screw which is long outside, means the screw head should be supported by proper compression and also using a proper size screw. Compress the fracture judiciously after releasing the fracture and do dynamic blocking. And these are some of the things. And you can write to me on Dr. B Shivashankar @gmail.com. Thank you very much. I thank Dr. Ashok Sham for giving this opportunity. I know over 22,000 people are there on this group, and at least about 3,000 to 4,000 people are listening to me just now. And I thank Dr. Ashok Sham to give this platform for everybody to listen to me. This is a great honor for me sitting in Solapur talking to you all. Thank you very much.
Thank you very much, sir. It was a brilliant talk, and it was around 1 hour 10 minutes talk, and you have great stamina for delivering this talks very passionately. So there are a few points that we'd like to discuss. Can you shed some more light on the importance of entry points for proximal femur nailing?
Proximal femur nailing, the entry is from medial to the tip of the trochanter. Even if we take the entry from medial to the tip of the trochanter, many a time the lateral part is more weaker. When we put the reamer, after putting the guide wire properly, when we insert the reamer, the lateral part gets removed more. That leads to varus position of the nail, and the screw will be in the superior part in the initial postoperative period only. So to try to avoid this, two things you can do. Either you can take a much more medial entry, which many people advocate, or when you're reaming, push the reamer more medially so that you will not reach the lateral cottage. The second thing, or I advocate better to take piriformis fossa entry. Piriformis fossa entry, if you take all this problem of pushing the lateral cottage getting reamed or the softer lateral wall getting reamed, all those things doesn't arise. And probably if you, how to get to piriformis is also very important. You cannot get to piriformis with the abducted reduced position. That's why I always fix the fracture. I stressed upon even a stable crack fracture also. I fix them with KVS, adapt it properly, then try to take an entry from the piriformis fossa. For me, for any nail in the femur, piriformis fossa is the entry, whether it's subtrochanter fracture or the intertrochanter fracture. But theoretically speaking, yes, medial to the tip of the trochanter is the tip entry side for these nails.
Right, sir.
Thank you.
Another question was, you have already stressed upon use on single screw versus double screw. If you can summarize the point again for single screw versus double screw, which will be helpful for the audience.
Okay, my space is full or it's still a small one?
You have
on the screen.
You have full space.
Okay. If a single screw is put, there's only one surface which is preventing it to cut through. If you put two screws, there are two surfaces which require to be cut through in the bone. So two screw is always better. And only problem of putting two screw is the surgeon feels it is difficult to put two screws. I have never faced problem of putting a two screw in the last 15 years, even in elderly thin neck of Indian patients. So friends, it's the technique. You have to learn the technique much more properly rather than going to a simpler solution of putting a single screw. Single screw is marketed because there are so many companies. Intertrochanteric fracture in elderly is a very common fracture next to the Polish fracture. The number of surgery being done is the commonest. Hip fracture is the commonest. So every company has to have its own share. Since PFN or a two screw system is patented by few companies, so they want to have their share. That's why they have come out with some modification like a helical blade or a derotational pin or a single screw or a lock-on system or a compression system or some bent given to the nail. All these things are given just to get a hold in the market. But if you can master the technique of PFN with a two screw system, that's the best implant available in the market. Just to give an example, if you are walking alone in a dark place, unknown place, you feel worried. If there is a small child holding your hand also, you feel more comfortable. The derotational screw does the same work for you. The derotational screw gives the support the cervical screw requires. And also the derotational screw, when you pass it properly, you know the exact length of the cervical screw you are going to use. So there is no question of changing the cervical screw required. So the fixation is always better when you use the screw for the proper size screw for the first time, instead of changing and reinserting a shorter or longer screw. So all these things can be done with two screw system. So I am totally for two screw system. If I have a fracture neck femur, I want it to be fixed with a two screw system like a PFN. Probably once the patent period is over, every company will come out with a two-screw system.
Right, sir. So about
another problem is two-screw system. If the surgeon feels little problematic for either the entry or putting two screws. So that problem of the surgeon has been advantageously taken by these market people to come out with a tip of the trochanter entry just by giving a small bend to the nail. And they say that you can take the entry from the tip of the trochanter, even 5 millimeter lateral to the tip of the trochanter, giving some more entry. So all those things have been taken advantageously, but definitely two-screw system is the best available as of today for intramedullary fixation of the neck fracture.
Right, sir. So about this trochanteric stabilization plates, do we decide it before surgery or intraoperatively? Is there any points which help us decide when to use them and when to not use them?
As I said earlier, Naveen came out, Dr. Naveen Thakkar from Ahmedabad came out about 6 years back, but that plate is still not available in the market except for few doctors, including him. Then
Right.
when my friend Dr. Shashikant Ganjale came out with this plate about 4 years back, I also liked the idea and I had kept it in my armamentarium. In each and every case I do nailing, this is always ready on table. But never I had the opportunity because I almost always get away by tightening the screw against the nail itself. Like by getting a good valgus reduction, I always get away with this. The only case I showed, I used last week only. The patient is still in the hospital, not yet discharged. The lady is 92-year elderly lady, the basic cervical as well as high subtrochanteric fracture, where if I had compressed it also, the problem of screw gradually cutting through was very, very high because of the double fracture, and that's why I used this. So there are definitely advantages of using a trochanteric stabilization plate. The advantage is the screw head will remain outside. It will not be lost within the medullary canal, within the bone core going that. But the disadvantage is you have to extend the incision. That's I normally don't like. I want to get a close reduction as far as possible and get the advantage of close nailing. Thank you.
Right, sir. So just last question. What is your take on severely osteoporotic fractures? How do you modify your technique, or is there anything else you will do during surgery or before surgery or after surgery for these fractures?
Normally, I don't modify any of those things before surgery, and I try to get the screw placed as inferiorly as possible. Sometimes my screw might cut through the inferior part of the neck, come out of the neck, and again enter into the inferior part of the head. This is how inferior I might go sometime in these fractures, and it will be very, very inferiorly placed. I never go it central or superior part of the head and neck. And I try to get valgus reduction. This is only two things I do in the immediate post-operative period. And during the course of healing, I try to give them calcium supplements. I initially give them on vitamin D injections also, and then I ask them to take teriparatide injections. But many of my patients, because the cost or because of taking, because I work in an area where the people are less educated, and my class of people hardly, if I prescribed about 50 people, 1 or 2 will take. But I definitely advise these people calcium supplement as well as teriparatide in these cases.
Thank you very much, sir. I think it was a very nice session talking to you on these complex issues. Thank you very much.
Thank you very much. Thank you. Bye-bye.